I am pleased this morning to introduce you to Professor Anette Schrag. She is here to talk about the ADepT-PD trial, and I will not get in her way any further. Over to you.
Thank you very much, Chris, for giving me the opportunity to talk about this trial. So this is a treatment trial for people with Parkinson's disease. And I'll just explain a little bit about the rationale for the study first, and then the nuts and bolts and how it is conducted and for whom. So the reason and the key aims for any treatment trial in Parkinson's are by and large twofold. Firstly, and that's what most trials have been to date, are to improve the quality of life of people with Parkinson's by treating symptoms. And the second aim of the more recent trials is to try and change the progression of the disease. So this trial is trying to do both, really. And just to explain how we're hoping to do that, quality of life in Parkinson's is obviously influenced by many different aspects. And the disease alone and the symptoms of Parkinson's disease can affect quality of life in many different ways. And obviously that varies slightly between different people depending on what the symptoms are and also their own personal circumstances. But a lot of studies have shown that amongst all the motor and non-motor features of Parkinson's, features of low mood and depression are really the most important ones for quality of life. And as I said, many studies have shown that, and clearly there are other features that are also important. The degree of impact on ability to perform tasks like dressing, eating, and so on, but also a lot of the non-motor features like pain or fatigue. And they are also, of course, very important, but depression is one of the key factors. So in order to improve quality of life, it is really very important to recognize and address and treat appropriately if somebody has low mood. And when I say low mood, that doesn't necessarily need to be full-blown major depression as is generally recognized in the general population, but in Parkinson's disease, it is often a slightly different type of depression or low mood, and it's often not recognized as a result of that. And we know that it is very, very common. At least 40% of people with Parkinson's disease do have low mood at any one time. And we also know that it is often a symptom that predates motor symptoms and certainly diagnosis by a number of years. And that and a number of other lines of evidence suggest that it is one of the features of Parkinson's, not just a reaction to symptoms. So it's an integral part of the disease and the symptom, like others, that does need addressing. So improving low mood is very important, but the question is which treatment is the best treatment? And there are psychological treatments and there are medications available, but the evidence for which of the medications, if medication is needed, is very low, and therefore the guidelines all differ. And this was the reason for this trial to be commissioned by the NIHR to find out which treatment is the best and how well do the available treatments work. But we were also interested in one of these treatments, one of these medications, in order to examine whether they can improve or affect the progression of the disease. And even if it is just a small difference in changing the course of the disease in the long term, in the long run, even a small change will make a big difference. And there are a number of approaches at the moment being trialed or considered. Most of them address the underlying pathology that we know is associated with Parkinson's, and that is the alpha-synuclein protein pathology. And that is also the target of this trial, because we know that nortriptyline, one of the two medications that we're trialing in the lab, can address this pathology and reduce the abnormal folding of this protein. So, in this trial, we're testing nortriptyline and also another antidepressant called escitalopram, both of which have an established safety profile because they have been around for a number of years. But as I said, it is not known which one is the best treatment in people with Parkinson's who have low mood. And as I said, we're trialing nortriptyline because there is some lab evidence that it can affect the underlying pathology of Parkinson's in general. So that's really the reason and the aim for the trial. And so the trial is conducted across the UK in different sites across the UK, but it can also be done completely remotely. With COVID, we completely revamped the trial in order to allow people from areas that, or people who are not able to come to hospital to participate in the trial, and the medication is sent in the post, and assessments can be done remotely. So we are recruiting from 30 sites, including in the peninsula, but also remotely. It is a trial for which most people with Parkinson's should be eligible, as long as they have some low mood, and that is always worth considering by checking with our key exclusion criterion, which is a certain score on the Beck Depression Inventory, which is a very standard tool or scale to check for depressive symptoms. And the key exclusion criterion is really people who are already taking one of a related antidepressant or had been on this within the 4 weeks of enrollment. And the other key contraindication is obviously if there are any contraindications to one of the drugs. And the assessments are there are several assessments clearly at baseline. And the key primary assessment for the low mood outcome is at 8 weeks, at which point we will assess whether someone needs to go onto a different antidepressant or whether they can continue in the trial. And then again at 6 months and 1 year. And the 1 year assessment is when we're particularly interested in the motor progression and the difference between the groups. So that's in a nutshell how the trial is conducted. Here are some of the contact details, including the local ones for Cornwall. But if it's difficult for anyone to come to these hospitals, as I said, we can also run it remotely, either from one of those sites or from the Royal Free in London, where I'm based.
Thank you very much, Annette. A brilliant, brief introduction. Thank you, indeed. This struck me as a rather unusual trial in the sense that it has multiple objectives, and it is also unusual in the drugs that are being offered. I mean, there aren't too many trials that I've come across that deal with this topic. So is one of the attractions that there's not many trials like this, and you better get on board this because this is the only one coming for some time.
Yeah, so as far as I know, that in the UK at least, there aren't any other trials for the aim to establish the best treatment for low mood. That is definitely unique in that in the UK. Mm-hmm. There are potential trials with potentially neuroprotective treatments as well, but they're often for very selected groups. Right. They tend to be for people who are very early in the disease, mm-hmm. And don't have really anything else majorly going on, mm-hmm. Because for those sorts of trials, which are often invasive or very involved, mm-hmm. They have to be very selective. Whereas in our trial, we are trying to be really pragmatic, and we are able to do that because these are drugs that are established and have been used for many years for indications in depressive disorders in people not in Parkinson's, but we don't really know too well how effective they are in Parkinson's.
Okay. The language that is used in the patient information sheet is, in my personal opinion, fairly technical. And you are introducing a community that may or may not be drug naive to some fairly, selective serotonin reuptake inhibitors, for example. I've been practicing that one. I hope the pill's as big as the title. But do you think this is going to, is this something you feel you must do in a document like this? Is it really necessary to go to this length at such an early stage?
So the patient information sheet, unfortunately, is pretty formalized, and it's very, it's long, but they always are long now for a treatment trial. And the reason for that is it's very important that anyone who enrolls in a trial where it's not known which medication they are taking, at least to them or their treating doctor, because that's obviously the important part of a randomized controlled trial, to be blinded to what treatment one is having. But there are very strict regulations to make sure that everybody knows exactly what they're letting themselves in for, what the ins and outs are, so they can make an informed decision. It has the disadvantage that it's sometimes a little bit impenetrable, but hopefully, as part of the consenting process, the person who is giving out the patient information sheet can summarize this and really translate this into normal language, because it's not a complicated trial to a degree, because we're not introducing different dose regimes and several different arms with the same medication, and it's a known drug.
Well, can I chase your comment about dose, because that's one of the notes I made for myself. The dosing in this trial is the same as you would encounter, or the same range as you would encounter in other uses of the drug?
Yes, absolutely. So because it's a pragmatic trial, we stuck to what the licensing is in the UK. So for both of these medications, so I should probably also just spell out again that this is two medications compared to placebo. So there are three arms. One is the nortriptyline, one is the escitalopram, and one is placebo. So there's a 1 in 3 chance of getting either of those. But both the nortriptyline and escitalopram are exactly the same dose as one would prescribe in routine practice.
Right. Okay. Can I reverse back into an issue we were talking about just now, which is the complexity of the language? You may or may not have read the Parkinson's UK introduction to the ADepT trial, which, apart from the use of depressant in the title, carefully avoids the use of the word of depression. It majors on the use of low mood and anxiety and other such. And I wonder if there's some difficulty in the research and clinical community about the use of the word depressive.
Yes, absolutely. So generally, in any, not just in Parkinson's, but there is often a stigma attached to the word depression, whereas most people recognize that they can have low mood. And there is quite a bit of research that in Parkinson's, depression or low mood are different to what they are in non-Parkinson's, because as I mentioned, it is a feature of Parkinson's, just like tremor can be a feature. Not everyone has it, of course, but a lot of people do. And in the vast majority, it is not major depressive disorder or bipolar disorder, which is really very, very rare. It mostly is low mood that doesn't reach the level of major depressive disorder.
Right. So how would you distinguish then between low mood and apathy?
Oh, that's a really good question. So apathy can be a feature of depression. It's one of the possible features of it that allows a diagnosis of major depressive disorder, but it is in some people present independently without any depression at all. It can be confused with depression because it might look the same if somebody doesn't talk very much or doesn't seem to be interested or motivated. But apathy as such is not associated with low mood. So low mood is really the key feature of what we're looking at.
Right. Okay. I have to say that as a sort of consumer who doesn't have this experience, I find it difficult to conceptualize, to understand what you're talking about, because I'm not there. I don't have this kind of thing so far, mercifully. It's very difficult for me to assess what you're saying. So I have to take it. I take it at face value.
With Parkinson's, there are so many possible features that one can have, but it's a different combination in everyone. So I think tremor is probably the easiest one to communicate about, because it's a key feature of Parkinson's, but not everyone does have a tremor. And if it is present, it might be a major feature or it might be a minor feature. And the same is true for both apathy and depression. So it may or may not be there, but it can be treated, and they may overlap, but they may not. And the key distinction is really, the key question is, does one have low mood? And then the Beck Depression Inventories, that's the scale that we are using. It's widely available. So if anyone wanted to check whether they are at 14 or above, then that could be easily done. But clearly the pre-screening that we do, if someone is in principle interested in the trial, would be to check with them whether they have features that would make them eligible for the trial.
Right. I'm thinking of because you do, in a sense, you have to sell this trial to people. They have to have a reason for it. And I mean, personally, I'm tell people as it is, deal with reality. You can't. I would start with the word depression or depressive or antidepressants. I wouldn't start with the word low mood or loss of enjoyment, because you finish up later in the conversation having to explain why you've now changed your language.
Well, most people, or a lot of people with mild depression, don't realize that this might be depression. And therefore, the screening process obviously will be rigorous to make sure that it only includes people who do fulfill inclusion criteria, but we wouldn't want to exclude people because it's not recognized. And we know that that's very common still. So even when people present with some features like that, then it often isn't recognized even at that stage.
I think this moves us on to the importance of the carer, the care partner in this transaction, that they are a much better observer of someone's state of physical being and state of mind than I am. My wife will tell you lots of stories about how she is a better judge of where I am than I am.
So that can often be the case. Obviously, not always, and low mood is a subjective feature, but people might not recognize it either. So it is something that one needs to probe and find out about.
Can you say whether there is a significant number of people coming forward as a result of a Care Partners initiative?
Oh, that's difficult to say, because clearly we would only include people who are very motivated themselves. But just from clinical practice, I often find that's the care partner who volunteers that information rather than the person with Parkinson's, and then initiating the conversation. I think that's absolutely a factor.
Right, I think we've dealt with the optics of the word depression, and we've probably beaten that one to death. Can I come back to the complexity of this trial from a drug point of view?
Yeah.
What is the success measure for this? What are the outcome measures that tell you whether this, that, or the other is the case?
So for the depression or low mood aspect, we're looking at the BDI, the Beck Depression Inventory, as our key outcome measure. And as I said, at 8 weeks, that's the primary outcome measure for that. And we're also looking at whether it's the effect is persistent at 6 months and 12 months. For the progression of motor features, we're primarily looking at the 12 months outcome. And for that, we're using a variety of different measures. It's the UPDRS, the Unified Parkinson's Disease Rating Scale, which is part of every trial in Parkinson's, more or less. And we are looking at that both on medication, on anti-Parkinson medication, and off, which might be a better measure for that. We're also including a wearable device. Obviously, that's optional. Not everyone will want to have that, but it's essentially a accelerometer to measure movement over a week. And we're using video recordings, which are analyzed through a digital algorithm of movements in order to get more sensitive measures, in order to be able to compare whether there's a subtle difference between the treatment arms, which we might not pick up with our clinical rating scales.
Right. The patient information sheet comments on the tricyclic family as exhibiting potentially delaying of progression features in the laboratory. I'm presuming that means in rats so far rather than people.
In Drosophila, in rats, in mice, that sort of thing, yeah.
Okay. Well, you'll know that the Parkinson's community is just a little careful about results with rats and mice.
Indeed, I couldn't agree more. But essentially, and also, of course, in cells, to look at the alpha-synuclein as a protein and how it behaves. So, but that's of course the reason to test this in a trial, because we can't just assume, because it happens in rats and mice, that it will translate into a clinical benefit. And because tricyclics are off patent, they have been around for a long time, they will never, or well, I wouldn't say they will never, but it's very hard to do a trial with this, a large randomized controlled trial, because there isn't a commercial interest. And I know the Cure Parkinson's Trust obviously has been very interested in nortriptyline, and that's also the reason why the Cure Parkinson's Trust does fund the motor aspect of the study, because of that interest.
Indeed, I wondered whether in selecting the drugs in the first place to put on trial, whether the cost of them was a factor for the NIHR decisions about what to go with and what not to go with.
Yeah, I'm sure that NIHR is always interested in the costs of treatments, because that's one of the things that they use to evaluate whether they recommend something. It may well be, but all of the antidepressants that are used in Parkinson's are actually off patent. So it wasn't really it wasn't really an active decision to exclude any particular medication.
I think perhaps that's one of the unique aspects of the trial, in that it does involve off-patent drugs, and therefore the only agency likely to fund the trial is the government.
Absolutely, yes.
The taxpayer.
Yes. So a lot of there are some new drugs that have been being developed to address the alpha-synuclein pathology. They are all new drugs, and so obviously they're expensive and commercial trials. There are some repurposed trials which are looking at different pathologies rather than alpha-synuclein, and the exenatide trial is an example of that, which is also using a drug that is actually used for a completely different indication for diabetes, to look at whether it changes progression of Parkinson. So it's not dissimilar in that regard, but in contrast to exenatide, it does specifically look at the alpha-synuclein aggregation, like some of the newer drugs.
Okay. I have one further question before asking you for if there's anything that we've missed. Side effects. One of the phrases of one of my, as it were, colleagues in this business of advocacy says that side effects are not compulsory. And of course, the more you publish side effects, the more likely it is that they will be reported. For example, I go back to this patient information sheet, where it says that in normal life, the tricyclic antidepressants are prescribed after SSIs have failed to do the job because of the higher side effect profile of the TCAs, tricyclic antidepressants. So does that not result? Will that not result in exactly that report from your trial figures?
Yeah, you're absolutely right. So in the general population, that is probably true for the comparison between SSRIs and tricyclics. In Parkinson's, it's a slightly different situation, because tricyclics actually have some properties that are helpful for the symptoms, for example, of tremor, or sleep. And in fact, amitriptyline, which is a related drug to nortriptyline, but older and generally a bit less well tolerated, is often used for sleep. It's very commonly used. And because of that, we're actually not excluding people who are on a small dose of amitriptyline, because it's so commonly used. Nortriptyline is much better tolerated generally at higher doses, at antidepressant doses, which is why we prefer that, and also, of course, because of the potential neuroprotective effects. But of course, yeah, in the patient information sheet, we do need to list, we need to be completely transparent and open about the possibilities of side effects. And clearly there always can be side effects with these medications. So we exclude people with dementia, because that is one situation where one probably wouldn't want to use those medications. But other than that, we're really staying within a very pragmatic approach.
Okay. So if I could ask you for a wrap up, just included in your wrap up, please, a comment about how quickly this would go into clinical practice. Whatever the outcome, how quickly it gets into.
So, and perhaps just before summarizing, I just want to thank also John Whipps and Sue Whipps, who are part of our trial team, in fact, and have been very, very helpful. So it is a trial with two medications that are in current clinical practice for people with depression, nortriptyline and escitalopram. And we're comparing these against each other and against placebo in terms of both the effect on low mood or depression, even if it is not major depressive disorder, if it's above a certain level. And we're also in the same trial looking at the effect of nortriptyline to delay motor progression. And that is the reason to do the trial over 1 year, as opposed to for the antidepressant effect, which we're looking at really for mainly over the first 8 weeks.
Right. Okay. All right. Thank you very much, Annette.
Thank you, Chris.
My apologies for an untidy end to that interview. My thanks again to Professor Schrag. Thank you to Annette for her time, attention and commitment. And I'd also like to thank Helen Matthews of the Cure Parkinson's Trust for facilitating this interview.